Okay.
Sir, we are live.
Okay. Okay. I'll start. Uh, hello. I am starting now. Hello. Can you hear me? Hello. Can you hear me? Yes. That's should I start? Yes. Okay. Okay. So we are live now, and I'm starting our first scientific session of Medical Society RIMS Imphal 2020-21. At the outset, I extend a very warm welcome to Professor A. Santa Singh, Director RIMS Imphal, and Professor Brogan Akoizam. He has not joined yet. And I also extend a warm welcome to Professor C.H. Arun Kumar Singh, Medical Superintendent, RIMS Hospital, Imphal, and all the head of departments of RIMS, faculties of RIMS, students of RIMS Imphal. Today, our Medical Society RIMS has taken a very small but precious step of conducting this webinar. And from now on, it will be easier to take further steps. And I thank Alkem Eurokia for helping us take this first step. I hope in the future we can arrange this Medical Society webinars using our own web portal. With these few words from my side, now I would like to invite Professor C.H. Arun Kumar Singh, Medical Superintendent of RIMS Hospital, Imphal, to speak a few words.
Thanks, Professor Kaku, the chairman of the Medical Society RIMS of 2020-21 session. Respected Director, Professor Santa Singh. Respected Dean, Professor Brogan Singh Akoizam, and other members of the Medical Society and participants, faculties of the departments, and my students, colleagues. It's a great pleasure for me to be here today as guest of honor at the inaugural function of the first scientific session of the Medical Society 2020-21 of the RIMS Imphal. The Medical Society is the platform for scientific activities of the teaching faculties and residents of the institution and research professionals in the field of medicine, where the latest achievements and upcoming challenges are discussed and where one can learn and gain knowledge on sharing their ideas and thoughts in the field of medicine. It's heartwarming to know that the practicing physicians, the learned professor of the various disciplines, the scientists, and other specialists across the various departments of RIMS are coming together to advance the education of the doctors and other related professionals, support the development of research, and facilitate the advancement of medical service towards the delivery of high-quality teaching in RIMS. Well, distinguished ladies and gentlemen, I am particularly happy that the first scientific session of the Medical Society 2021 of RIMS Imphal will enhance our knowledge. This meeting will provide real opportunity for members of this professional association to frankly and openly discuss the happening things in the medical sciences today, the training and services given particularly in our region. It is my hope that this conference will lay a foundation stone to address the unmet needs and medical teaching and research in all the branches so as to demonstrate a high standard of medical care and education. To conclude, I thank the organizers of this scientific session of Medical Society, RIMS, for having invited me to this gathering. Rather, from my office, I wish you all a productive and a meaningful meeting. Thank you all. Thank you, professors.
Thank you. Thank you very much, sir, for your encouraging speech, sir. And I'm very proud that more than 350 doctors have joined this webinar. Now, I think the number will increase in a few minutes. Now, I request our respected Director RIMS Imphal to give his inspirational speech. Sir.
Thank you, Dr. Kaku, and the chairman of this our medical society. Can you hear it?
Yes, sir. Yes. Yes, sir. We can hear, sir.
Okay. And Medical Superintendent Professor Arun and Professor Kaku, all my dear colleagues and the head of department, faculty, and my dear residents, doctors. I am delighted that the Medical Society is starting the scientific session after the long gap due to COVID. And I just want to congratulate all of you. And I'm very, very happy that the first session of 2020-21 will be starting from today. But then the way this time the Professor Kaku and the team's arranging is very encouraging, and it's very good for our college institute. And just now I come to know that more than 300 people are attending this scientific sessions. So I know that they will deliberate all those scientific research papers, and this will encourage our resident and the faculty to do more research. And of course, I will be analyzing critically analyzing about the management of the patient, particularly in the COVID times. So this will be innovative ideas, and doing this like this will be really good. And we should know about we also should know how to prevent the COVID, so that COVID appropriate behavior that government of India is introducing, and all of us should follow it and try to spread it. And thank you so much for inviting me in this scientific session. I just want to congratulate all of you again. Thank you so much.
Thank you very much, sir. Thank you very much for your encouraging, inspiring words from you, sir. We are very proud that you are the patron, you are the mentor of our medical society. Thank you very much, sir. Thank you again. Now, I hand over the proceedings to Dr. Memchobi Panjobam, Secretary of our Medical Society RIMS, to start our scientific program. Thank you. Thank you very much, everyone.
Thank you, sir. Good afternoon, respected Director, respected Medical Superintendent. Though our respected Dean is absent due to some unavoidable circumstances, we would have been very delighted if he had been here also. Anyway, and my respects to all our beloved teachers, PhD students, and colleagues. Today we are conducting the first scientific session of Medical Society for the year 2020-21. We have been compelled to do this in webinar form because of the current pandemic. In today's session, we have 6 papers from 6 different departments. And at the outset, I would like to announce that among the 6 papers, the best papers will be selected by the executive members of the Medical Society. The criteria of judging the paper will be based on the study design, content, relevance, language, and presentation. And best paper winner will be announced later on. So the first paper in today's session is from the Department of Orthopedics. The paper is titled Biplane Double Supported Screw Fixation of Fracture of the Femoral Neck in patients, a prospective study in RIMS, Imphal, to be presented by Dr. Biju Sarangam and moderated by Dr. Rishikanta Sharma. I request the speaker and moderator kindly to come up on the stage.
Mute it all.
Everyone, please put yourself in the mute mode. Mute your mics, please.
Good afternoon to all. Today I'll be presenting a paper on the study of the human fracture, which is by this newer method, which is called by-band double supported screw fixation. Why we did this study was in conventional form of screw fixation, we found that we found the failure rate is quite high. It's around in some studies it shows that around 40%. And the purchase is at the metaphysis regime, which is a cancerous bone, weak part of the bone. Coming to the introduction, as we all know that hip fracture is quite common in the population, in general population, and the majority of population involved are elderly, and most common mode of injury is trivial trauma, which is fall from the standing hand. And the most commonly practiced operative treatment options available are the screw fixation, which can be conventional or modified form, or arthroplasty, which are many arthroplasties, or total hip replacement. In my study, the aim and object was to evaluate and assess the clinical and functional outcome of BDSF technique. Coming to the materials and method, it was a prospective descriptive study of a duration of 2 years done in our hospital rooms, and the sample size was 58, but unfortunately we could collect only 47. So 47 cases were studied and analyzed. These are the inclusion and exclusion criteria: age 40 to 90, guardian type 1 to 4, which is a classification of neck fracture based on the displacement, and the fresh fracture meaning up to 3 weeks of time. All the patients are taken into consideration, and contraindication of arthroplasty. In the exclusion criteria, patients do not give consent, and patients associated with comorbidities like diabetes, diabetes, and hypertension. The outcome that I wrote we used to measure was Harry Seal score modified, which has a total score of 100, and it was rated into excellent, good, fair, and poor in the following numbers. This is a performer of Harry Seal score, which tells which has the component of the grading of the pain. Then next we have the gait, which tells the patient is able to walk or how much distance it can walk. The functional activities like the patient is able to stand up with support or without support, or patient is able to wear shoes, socks to do general activities, or patient is able to sit or use public transport. And then in the presence of in the presence or absence of deformities, or by measuring the range of motion or any fixed deformity, fixed flexion, adduction, or range of motion deformity. In procedure, briefly, when the patient is put in the supine position on the fracture table is used, and a mild fraction internal rotation and the 10 to 15-degree abduction was used to reduce the fracture, and the approach is quite minimally invasive, which is with a straight lateral incision inferior to the greater diameter of 6 to 10 centimeters was given. And with the help of guide wires and intensifiers, the 3 screws will be placed into vertically oblique planes. This is a diagram depicting these 3 screws, showing these showing the orientation and position. Here we have these 2 red color. This area is called calca femoral. This is a dense part of femur neck, and this and then laterally we have the cortex. So this is the difference between the conventional and the modified. In this method, there is 2 supporting points. One is from the cortex, lateral cortex, and second is from the calca femoral. And this support is given by this 2 distal screws. And this is a diagram by mechanics showing a comparison between the conventional and this PDSF. In conventional, as we can see, if a pressure of 100 kg is given above, the resultant pressure will be exactly the same, and it acts. And in case of PDSF, the resultant stress is reduced. As we can see, the load acting at the B is A minus F. And this is a picture of one of our patients on the post-operative day 1 after the PDSF. In our study, the results are as follows. The average age was around 65, which is on the old age group, and among them, female were the most common. Female gender was the most common, and the mode of injury was fall trauma from standing height. And the garden type is the most common was type 4, which can be due to the strong muscle attached to the femur bone, so it tends to displace the fracture area. Then osteoporotic rate was 51.1%, and radiological urine was attending 83%. The Harris Hip score modified form was measured at 3 months and 6 months, and the average at 3 months was 55.85, and the 6 months was 77.04. And this is the distribution of Harris Hip score at 3 months and 6 months. As we all can see, at the end of 6 months, the excellent and good percentage, it comes around 85% out of 100. In complications, we face total of 4 cases. 1 case of hip and thrombosis, which was successfully treated later on, and the 3 cases of avascular necrosis of the femur head. Limitation we faced was due to the long follow-up period and the patient for compliance on the patient, we lost 2 patients. And since PDSF is minimally invasive and mainly done at the CR, there is always a risk of radiation exposure. Coming to the conclusion, management of femoral fracture is always a challenge, but with PDSF, it provides a good clinical and functional outcome. It is cost effective compared to hemiarthroplasty and body replacement. It is quite cheaper, and then in terms of biomechanics, it is quite stronger than the conventional screw fixation. So the biplane position of the screw provide a reliable, stable fixation with good pulses at a strong cortical region of the femur. Thank you.
I invite questions from the house.
You are doing a new technology, new technique. It is ideal to compare with standard technique. So what is you have said is because of you have done one technique and you have to do that. But ideally, whenever you do any study, you ideally compare with standard. Then only you move on to that.
Any patient developed vascular necrosis of the neck of the head?
Yes, 3 patients.
Pardon?
3 patients developed avascular necrosis of the head.
Recognize those cases.
Sir, they have to be done after passing.
And in one of the complications you highlighted is brain thrombosis.
Yes.
Any prophylactic, all the cases like the prophylactic treatment or not?
No, sir. So it depends on the patient.
Luckily, in the report, cases are not that obese. In the records, cases are very obese, so no one could have defined
Yes.
that given before.
Yes, sir.
What is the duration of the operation?
Duration, usually 1 hour to 2 hours. It takes.
Very nice presentation.
Any other questions? Online questions? So I request the moderator, Dr. Rishikant Sharma, time to moderate the paper.
Actually, as Dr. Vijay has already highlighted, tumor neck fracture is one of the most common. Tumor neck fractures are one of the most common fractures we encounter in operative emergency. With the most of the patients comprising the whole age group population because of the osteoporotic nature of the bone. So the gold standard in these patients is usually total replacement. But in many of the patients, due to comorbid conditions, many patients are not fit for this extensive procedure, hip replacement. So we need other options. So one is conventional screw fixation, but in conventional screw fixation, due to the osteoporotic nature of the bone, there is not much bone in the neck and the head of the femur. So the failure rate is very high as around 40 to 50% in imported cases. So in Bulgaria, in 2007, they have come up with this technique. So like in this, they have tried to, in conventional screw fixation, the screws were taken put in the metaphyseal region, which is the main osteoporotic area. So in this new technique, they have tried to bypass the osteoporotic part, that is metaphysis, and they have tried to get support from the medial calcar and then the distal diaphysis, so that there is stronger support. There are reports like there are 98% and 95% success rates in European studies. So we have tried to see in our own population, and we've got around 93, some lesser success rates may be contributed to poor and then late presentation of the patient. Usually here we get patients 1 week old, 2 weeks old, because in higher centers, neck tumor fracture is usually emergency surgery. So maybe according to that, I must conclude that Dr. Vijay for this working on this, so we give the confidence in here we get a platform to work on. Thank you.
Thank you. I request all the speakers and moderators kindly to stay till the end of the session. We can expect some online questions at the end of all the papers. The next paper is from the Department of Physical Medicine and Rehabilitation. The paper is entitled "To Compare the Efficacy of Ultrasound-Guided Pulse Radiofrequency Ablation and bupivacaine Block of the Suprascapular Nerve in Reduction of Pain and Disability in Hemiplegic Shoulder Pain," to be presented by Dr. Mayantan Janet and moderated by Dr. L. Nilachandra Singh. I request, sir. Thank you.
Very good afternoon to all. Today I'll be presenting a paper entitled "Comparison of Ultrasound-Guided Pulse Radiofrequency Ablation and Bupivacaine Block of Suprascapular Nerve in in reduction of pain and disability in hemiplegic shoulder pain. Stroke is the second leading cause of death and it is the third leading cause of disability worldwide. The incidence ranges from 0.2 to 2.5 per 1,000 per year, and the prevalence of stroke in India is 154 per 100,000. Hemiplegic shoulder pain is that pain which is present at rest during passive or active movement on the hemiplegic side after stroke with no direct relation to trauma or injury. The prevalence can be as high as 70% in the first 12 months following stroke. It is one of the most common and distressing yet preventable medical complication of stroke. It limits the range of motion, causes joint contraction, decreases hand function, and delays the functional recovery in patient, which limits the activity of daily living and can be a major source for depression. This is a posterior view of the shoulder showing the neurovascular and neuromuscular anatomy. This is a radiofrequency ablation machine which is available in our department and it is the only RFA machine which is available for pain intervention in this region. It is a neurolytic or ablative technique which causes controlled tissue destruction by means of thermocoagulation. It is minimally invasive and target selective. The reason why we conducted this study was because hemiplegic shoulder pain is one of the most common distressing complications of stroke with a very high prevalence. It extends the duration of post-stroke hospitalization and is a major factor that hinders appropriate rehabilitation. Moreover, there is no consensus available on which treatment option is the best, and there are very limited studies to prove which treatment modality is available. The novelty component of this study was that it has a larger sample size compared to other preliminary studies in which the comparison was done only with placebo, and in this study, the comparison is done with a standard treatment. The aim and object of my study was to compare the efficacy of ultrasound-guided pulse radiofrequency ablation and bupivacaine block of suprascapular nerve in reduction of pain and disability and hemiplegic shoulder pain. It was a randomized controlled trial conducted in the Department of EMR for a period of 2 years, and patients with hemiplegic shoulder pain attending the OPD of EMR during the study period were included. In inclusion criteria, age ranging from 35 to 65 years were included who were diagnosed case of stroke within the 12 months and who had a VAS score of 5 and who were willing to participate in the follow-up assessment. The exclusion criteria included patients with cognitive deficit, with any history of inflammatory arthritis or any history of steroid injection. The sample size was calculated to be 41 in each arm based on the following formula. And like so, the study group were given pulse radiofrequency ablation and the control group was given bupivacaine block. Patients with hemiplegic shoulder pain meeting the inclusion and exclusion criteria attending the PMR OPD on Mondays and Fridays were recruited and block of 4 randomization was done. Age, gender, the site of affection, duration of symptoms were the study variables, and the outcome measures were visual analog scale, the shoulder range of motion, and shoulder pain and disability index. This study was approved by the Research Ethics Board of RIMS and it is registered in the Clinical Trials Registry of India. Informed consent were taken and there was no conflict of interest. This is an algorithm showing the intervention in group A and B in which the follow-up assessment were done at 1, 4, 12, and 24 weeks post-intervention. This is an image showing the insertion of the radiofrequency electrode under ultrasound guidance. For statistical analysis, repeated measure ANOVA, t-test, and chi-square test were used, and p-value less than 0.05 was taken as significant. Table 1 shows the baseline characteristic of the patient in group A and B, and it was found to be not significant. Table 2 shows the outcome measures in the study and the control group, which was found to be decreased in the 4, 12, and 24 hours follow-up with p-value less than 0.05. The overall improvement was significant at 24 weeks, and in the intergroup comparison, the improvement was found to be more in the RFA group. Similar findings were also obtained in studies conducted by the following researchers. Apart from the short follow-up period and And except for mild pain at the site of intervention, there was no significant side effects. And lastly, to conclude, I would like to highlight that because the conservative treatment of hemiplegic shoulder pain takes a long time to improve pain, and it hinders the rehabilitation of stroke. And secondly, pulse frequency ablation of suprascapular nerve may be considered in clinical practice for its repeatability, more comfortable process, and shorter duration of treatment. Thirdly, pulse radiofrequency ablation of suprascapular nerve provides greater pain relief and disability reduction, and therefore can be the preferred treatment modality for managing hemiplegic shoulder pain. These are my references. Thank you.
Very nice paper. I would like to invite questions from the house. Any queries, questions? Online questions will be asked at the end of the session, at the end of all the papers.
There are other knobs other than your suprascapular knob,
Yes, sir.
like axillary,
Yes.
pectoral. How do you address those now?
Sir, the shoulder joint is supplied by the suprascapular nerve as well as the axillary nerve. But the main,
lateral pectoral knob.
yes, sir. But the components of the suprascapular nerve is 70%. It supplies 70% in the shoulder joint. Since the maximum supply is by the suprascapular nerve, and because of the ease of the approach, we are targeting the suprascapular nerve.
So they don't have any difference in the persistence of pain doesn't matter because those are the knobs. You say many sometimes like that. Axillary and lateral pectoral are there. And you have the pain for the radio frequency.
The suprascapular nerve already has supplied 70%, which is more than half. And then moreover, this technique is very effective because the recurrence rate is very low. And we have and there was no recurrence of pain in most of the patients in our study. And this reduction of pain can last up to as long as 2 years if it is done properly.
And next question, how do you do it?
Once only in that sitting, once 10 ml of 0.5% bupivacaine. No, sir. The reason why, even though bupivacaine acts for a short time, the reason why bupivacaine is effective because bupivacaine breaks the pain spasm cycle. And when we break this cycle, we are giving physical therapy to supplement our the block of the suprascapular nerve. We are giving physical therapy supplements.
Right.
Any more questions from the house? May I take this opportunity to say that I'm indeed very happy that 453 doctors are logged in right now and listening to the papers very much. May I request Sir Niladhar Singh to moderate the paper.
Thank you. So before I moderate the topic, also I want to thank our respected Director of Science for installling this RFA lesson in our department. Because of this, we are doing a lot of intervention, and this is the only basic available in all notes division used for pain intervention. Thank you once again, sir, for your help in the department. Coming to the topic, I thank Dr. Jena for your beautiful presentation. As she has mentioned also, stroke is very common now. In 1 lakh population, the infection is around 165, and the third disability worldwide. So we get into this, and the hemiplegic shoulder pain is again so common that in the first 12 months of after stroke, the incidence is around 70%. So we have to manage this, and it's very distressing also. But this can be prevented if we take up early and do proper therapy for intervention. So one such thing is radiofrequency evaluation. It's a very effective, approved, and very safe, concise, and precise result available. Where a particular drug is selected by using image guidance identified ultrasound. In our case, ultrasound use, sometimes we use CR in other cases for pain intervention. So there is no side effects we are using ultrasound. Radiation exposure is not there. So this can be one of the treatment methods. Since there are no specific guidelines, this treatment should be followed for maintaining the selected disorder. So we are following this. Remember, we have studied LCS result also. The study population was very less. And in our case, we follow only up to 24 weeks. But if it is done properly, the effectiveness lasts even more than 2 years or so. So just to supplement the answer given by the tenant, so we give, even though it was very less and in limited time, it's a approved method for intervention now. Along with this block, we have to go for other physical therapy and along with that exercise program. But we are following both approach. So this is how it's effective. So to conclude this treatment method, we can recommend to manage disorder patient, and we should take that. And my home message to all this is one of the effective treatment, approved effective treatment for this patient.
Thank you, sir. I would like to remind the executive members of the Medical Society kindly to strictly adhere to the study design, contents, relevance, language, and presentation while awarding marks to the speakers. The next paper is from the Department of Anatomy. The paper is titled Limb-Body Wall Complex, a case series to be presented by Dr. Zoshila Devilashantan and moderated by Dr. Irugam Devin Singh. I request the speaker and moderator kindly to come up on the stage.
Very good afternoon to the respected teachers and my dear colleagues. The topic of today's presentation is Limb-Body Wall Complex, a case series, moderated by Dr. Irugam Devin Singh from the Department of Anatomy. First, I would like to give a brief introduction about the limb-body wall complex. Limb-body wall complex is a rare polymalformative fetal syndrome characterized by wide spectrum severe anomalies in the body wall. The defects include craniofacial defects like extensive-body encephalosis or facial cleft, the anterior abdominal wall defect like thoraco and or abdominoplastis, and a limb defect like clubfoot's rotational defect, absent limb. And the other associated anomalies are genital abnormalities, amniotic vein, single umbilical artery, renal anomalies, cardiovascular anomalies, etc. And the incidence is about 0.32 per 1 lakh birth. The majority of the affected fetus it undergo intrauterine death, and it has no sex or familial predilections, and it's invariably fetal. This is a case of a 13-week fetus, male fetus, which was collected from the Department of Obstetrics and Gynecology, RIMS Imphal. And on external examination, here we can see this one is the umbilical cord, and the anterior abdominal wall defect it is present above and left to the umbilical cord. And the eviscerated organs which you can see here is this one is the liver, this one is the small and the large intestine, the stomach it is present over here, and a spleen. Here we also can see a frontal encephalosis, cleft palate, and a malformed nose was also seen. There was amputations of the second, third, fourth of the right finger and left big toes, which was with a fibrous vein ecdysium, and there was a bilateral clubfoot was also present. From the radiological examination, we have confirmed the presence of this encephalosis, and on internal examination, the lung and the heart were normal. And this is another case of 30-week fetus. This one is the umbilical cord, and the defect it is present left to the umbilical cord. And the organs herniated, it includes here the liver. This one is the kidney, small, large intestine, ureter, urinary bladder, gallbladder, stomach, and pancreas. Even though there was no amniotic cover present, but a remnant of amnions were seen at the margin of the abdominal opening. There was no craniofacial defect present in this fetus. The skeleton abnormalities, it included a hyposcoliosis and hypoplasia of the lower limb was present. The lower limb were malrotated. And in this picture, it has shown the presence of ambiguous and external genitalia with a complete hypospadias. On internal examination, there was no cardiac anomalies. The lungs were normal and within the thoracic cavities. The spleen was also normal. Small and large intestine were filled with meconium. And here, this one is the distal part of the large intestine which was dilated. This one is the hydronephrosis of the right kidney with a normal right ureter. The left ureter, the left kidney, and the urinary bladder were normal. Here in this image, it shows the left lower limb hypoplasia with small and short of the left femur when we compare with the right femur. In the discussion, the limb-body wall complex is also known as the body stock syndrome. It is a rare anxiety characterized by severe malformation. Most fetuses are aborted either spontaneously or by medical means, others are stillborn. The diagnostic criteria for limb-body wall complex are still being debated, but the most commonly quoted are those originally set forth by the Van Allen et al. In 1987. With the presence of two of the following three malformations is necessary for the diagnosis, like extensive-palio or encephalocele with facial cleft, thoracoid or abdominal slices, and limb defect. By Russo et al. In 1993 had given two distinct phenotypes. That one is with craniofacial defect or placentocranial phenotypes with a characteristic of encephalocele or exencephaly, which was associated with a facial cleft, amniotic vein sequence, amniotic adhesions. And another phenotype is that type 2 is without craniofacial defect or placento-abdominal. They are often present with urogenital anomalies, anorexia, lumbosacral meningosus, and placental anomalies like presence of short cord, persistence of extraembryonic coeloms, and intact amnions. Sahinoglu et al. In 2007 had proposed a new classification. The type 1 is with craniofacial defect and intact thoracoabdominal wall. In type 2, the defect is supraumbilical and there was a normal cloacal structures are detected. In type 3, the defect is infraumbilical and the cloacal structures are almost always malformed or absent. Even though the etiology remains unclear, 4 theories on the pathogenesis of body wall complex have given. One is the Tropin et al. In 1965, that is the early amnion rupture theory. Primary rupture of the amnions is due to the formations of the amniotic vein. This is the vascular disruption theory by Van Allen in 1987, interrupting the normal embryonic blood supply and mucogenesis. Stratus theory 1930, that is a jaundice effect with early embryonic maldevelopment. And last is the Hardwick et al. 1989 and 1991, which was the most accepted theory. Early embryonal dysplasia, disturbance of the embryonic folding process. Here in the present case, it had a complex cranial and abdominal anomalies, which was observed in the case 1. And it seems to favor with placentocranial phenotypes according to Russo et al. 1993 and type 1 according to Sahin et al. And the case 2 had a characteristic of placento-abdominal phenotype according to Russo et al. And type 3 according to Sahin et al. 2007. So in the conclusion, the limb-body wall complex is a syndrome with multiple malformations. Most of them are aborted or stillborn. And for those who are live-born, the prognosis is very poor. There is still lack of an etiological theory which we can explain all the anomalies. These are the references. Thank you.
Very nice presentation, Dr. Sheila. In fact, anatomy is the backbone of medical science, so I think it should incite or arouse lots of curiosity from the audience. Any questions, please?
take the total from the research board for this study.
Yes, sir.
In other words, what are the issues in your study?
Like collecting of the features.
Yeah, who is the owner of this business?
Actually, we used to take permission from the obstetric and gynecologist to collect these abnormal aborted features.
Who has ownership of this? Because you cannot operate without the risk.
Yeah. For actually, we used to take permission for collecting those features for our study.
Information is like for this study, that is in the specimen in the hospital, that is you should get a result from medical spread. That is very, very important. This is that.
Any more questions? Madam Gayatri?
Is there any genetic anomalies associated with these malformations?
Actually, ma'am, over here in my studies, we didn't get that opportunity to do those genetic tests. But in when I read from other studies, there is no genetical issues connected with these abnormalities.
There are no more questions. I request Dr. Irumul Devensen kindly to moderate the meeting.
Good afternoon. LPWC is a very rare condition, and I think we get to see such cases in the very rarely in the clinical practice. Now, actually, there have been at least 4 or 5 theories regarding the etiology of this condition, but none has been able to explain all the deformities that are found in this condition. Now, about the genetic factors, generally speaking, it is regarded that there is no genetic basis for this condition, but there are some reports claiming that there are some related defective genes involved in this condition. Now, the malformations are very serious, and in addition to the malformations which are present in the face and head, in the abdomen or thorax, or in the ribs, there are also associated a lot of associated malformation. So, for example, malformations in the immune system, in the heart and lung, in the umbilical cord, where you can find single umbilical artery. Since the malformations are very serious, the prognosis is very poor. Thank you.
Thank you for sharing a very interesting paper with us. The next paper is from the Department of Pathology. Study of uterine rupture in peripartum hysterectomy cases, a 10-year review, to be presented by Dr. Yumnam Shamin, Senior Resident, and moderated by Dr. Gayatri Devi Ukramam.
And no, I not smart or when I call them, I'm going to buy water over the blade.
A very good afternoon to everyone. I'm Dr. Yumnam Shamin, and today I'll be giving a presentation titled Study of Uterine Rupture in Peripartum Hysterectomy Cases. It's a 10-year review. So briefly going into the introduction of uterine rupture. Uterine rupture during pregnancy or labor is a rare event and frequently results in life-threatening maternal and fetal compromise, and is defined as tearing or disruption of the uterine wall with or without involvement of the overlying peritoneum. It can either occur in a native unscarred uterus or in uterus with surgical scar. So there's increases of rupture and is associated with various conditions like there is preterm delivery, high parity, previous cesarean section, uterine anomalies, abnormal placentation, or instrumentation during labor. In developed countries, the rate of unscarred uterus is quite lower compared to the developing countries, and the continuous trend of cesarean deliveries has increased the number of women exposed to the risk of uterine rupture. In India, the report incidence varies from 1 out of 1,633 deliveries to 1 in 346 deliveries. And maternal death as a consequence of uterine ruptures also is variable and is higher in developing countries. So in this near-miss event, peripartum hysterectomy, which is a life-saving surgical procedure, is usually performed to prevent maternal and neonatal mortality. The aim of our study is to evaluate the pathological findings of uterine rupture in peripartum hysterectomy specimen during a 10-year period. Our study design is a cross-sectional study done from August from 2010 to July 2020. 22 cases of uterine rupture were studied in the Department of Pathology, Regional Institute of Medical Sciences. 105 peripartum hysterectomy specimens were selected and included for the study. Peripartum hysterectomies for non-gestational malignancies or other elective indication or under 24 weeks of pregnancy were excluded from the study. The specimen received were fixed in 100% formalin. Majority of the specimen were opened by a complete longitudinal anterior posterior section. The side, lateral, and dimension of the uterine rupture were recorded. Sections were taken from the edges. Paraffin blocks were sectioned and stained. The slides were studied and histopathological diagnosis was done. The gross and microscopic histological findings were analyzed statistically in relation to the age, parity, number of previous cesarean sections, and other associated comorbid features. Coming to our results, during the 10-year period, 22 cases of uterine ruptures were diagnosed. The rate of rupture in the present study is 0.22 per 1,000 births. Mean age was 31 years, and the majority of the patients were in the age group of 30 to 39 years. There was a 100% occurrence in multiparous women, with the relation being significant, evidenced by p-value of 0.02. And the site of rupture was most commonly in the lower uterine segment. And we also found some associated findings along with uterine rupture, like abnormal placentation, leiomyoma, abruptio placentate, abnormal site of placentation in the mode. Prior history of cesarean section was noted in 6 cases, with 4 cases twice and 2 cases of 1 previous cesarean section. This is the gross picture of a peripartum hysterectomy specimen showing adherent placenta. Another gross picture showing uterine rupture as indicated by the arrow. This is a low power view of section from the uterine rupture showing hemorrhage, areas of hemorrhage, and muscle disruption. This is a low power image of a placenta accreta slide where you can see the coronary villi implanting directly onto the myometrium. This is a low power view of a placenta accreta where the section shows coronary villi infiltrating into the myometrium. This is another picture of placenta accreta. And this is one of the considered finding of invasive mode, which we found a case where we can see coronary villi infiltrating into the myometrium. And this is a low power view, high power view of the section of lower uterine segment showing trophoblastic tissue implanting into the fibrocollagenous scar as seen here. And another low power view of a leiomyoma. So coming to the discussion, the rate of peripartum hysterectomy in our study was 1.24 per 1,000 deliveries, and other studies shows varying rates. Mean age was comparable with other studies. Similar to our studies, other studies have also found increasing rupture rates in women with parity 2 and above. The frequency of uterine rupture in the present study was 0.02, which was similar to some studies, while other studies also showed very high rates compared to our study. Rupture of lower uterine segment is seen in majority of the cases, and is finding to similar studies. The differences in the contractility of the
upper and lower segments, and hence asynchrony during labor might be responsible for this unpredictable outcome of rupture. We also observed scarring in 6 cases of uterine rupture with previous history of cesarean section, and the correlation was not significant, probably due to the lesser number of the cases, though other studies show significant association. Importance of histological examination of the rupture site was emphasized by Kilan et as few of the expanded dilated capillaries are associated with amniotic fluid embolus, and thus alerting the gynecologist obstetrician for a systemic bleeding. Perinatal mortality was seen in 3 cases, and uterine rupture is an independent risk factor. Some limitation we found in our studies is a single center study, and it is a small sample size. We cannot establish significant some risk factors. Previous operating history and intrapartum risk factors are not included. The higher rate of occurrence of histologically proven uterine rupture in the current study is a reflection of the prevailing healthcare facility in the peripheral region. Innovative strategies are needed to address this problem. Lastly, I would like to conclude by saying a pathologic diagnosis is important so as to explain indication of peripartum hysterectomy and also to highlight the cause of hemorrhage. It will also confirm the clinical or imaging impression of the case. Unexpected associated findings were also diagnosed on examination. Studies on abnormal placentation in the lower uterine segment and its association with uterine rupture and other obstetric complications is required understanding the pathophysiology of this obstetric events. Further studies of histomorphology of intermediate trophoblast using IHC and molecular studies will give new insights regarding the pathophysiology of this abnormal placentation. These are my references. Thank you.
A very relevant presentation in these days of frequent maternal deaths. I invite questions from the audience. Sir, any question?
Doctor,
Yes, sir.
all these were recently.
Yes, sir.
We were any kind of support like that because of technical difficulty.
Subtotal hysterectomy is usually, as far as the literature and the studies show, that the subtotal hysterectomy depends on the condition of the patient, then the extent of the rupture. So based on that, they will do subtotal or full total hysterectomy. Sir, yes, most of them were total hysterectomies.
Any other hysterectomy developing bleeding? Any percent of the series?
Yes, sir. There are cases of where we have received the peripartum hysterectomy shows atony, that like the uterus was very bongy and it was not contracted. But we have not included that in our study. Most of sir. Yes, sir. Oh, sir, that I'm sorry, we have not followed into the clinical patient's history. So this is only what I have covered. The data is only from the what we have received the form, the patient, and from the perinatal hysterectomy specimen that we received. We have studied that, and that's the data which I have presented, sir.
Just for your knowledge.
Yes, sir.
After hysterectomy, patient developed bleeding.
Yes, sir.
What procedure will you do? Any ligation or vessel?
Yes, sir. Yes, sir. That also will be yes, sir.
Or nowadays,
embolization. Yes, sir. Yes, sir. Yes, sir. So depending on the seriousness of the rupture, either it will be repair or either hysterectomy is usually performed.
Any more questions? In fact, I have a query, Dr. Shamin. I'm slightly confused. Did you say this is a cross-sectional study and a 10-year review? Yes. It is a cross-sectional study. Yes, and also a 10-year review. Right.
It's actually a retrospective and prospective study.
But you said cross-sectional. Right.
Yes, ma'am. Because
isn't that a little contradictory? I would like you to explain on this.
Usually cross-sectional studies are done at the given given period of time where the cause and the effect is studied. So we didn't have any any other the history that we received and the specimen that we received that we have studied. We have not got into details into the further clinical history or follow up the patient. So I feel it's a cross-sectional study. Thank you. I request Madam Gayatri to moderate the meeting. Good afternoon. Good afternoon, my dear teachers and my colleagues. The sole purpose of this presentation is that uterine rupture is a dreaded complication, and this may be emphasized even in our Manipuri custom also. We usually have a Hamapalvi Chakoba. Because of this, probably, because of these dreaded complications, Manipuris, I think they are more advanced in knowing these complications of pregnancy. Uterine rupture, what we found from this study, while studying uterine rupture, we found that there are also associated findings which may lead to the rupture. And the most important finding was scarred uterus. A scarred uterus, probably because it had suffered repeated pregnancies or because the patient had undergone a cesarean section. Not only this, a scarred uterus becomes a background for the development of abnormal implantations and abnormal placentation, which further leads to rupture again. So the findings of our study, I think it will highlight to one and all the importance of this lower segment where lesions can occur and lead to complications. So I take this opportunity of thanking our colleagues in the Obs and Gynae to send more samples. They are sending, and I request them to continue sending the specimens so that we can study further the features or the characteristics of the intermediate trophoblast, which are responsible for bringing out or for causing abnormal placentation. And I thank the Medical Society for conducting such a wonderful webinar where we can convey our findings of the study. Thank you. Thank you, Team Pathology, for a very nice presentation. The next paper is from the Department of Urology. The paper is Comparison of the Outcome of Extracorporeal Shockwave Lithotripsy with Percutaneous Nephrotomy for kidney stones of 1.5 to 2 centimeter in size and plus 250 to 1000 HU intensity, to be presented by Dr. Anurag Kumar, Senior Resident, and moderated by Professor A.K. Kapoor Singh. Dr. Anurag.
Thank you, ma'am. Very good afternoon to all of you. I am Dr. Anurag Kumar, Senior Resident in Department of Urology, RIMS, and I am presenting a paper on the topic of comparison of outcome of extracorporeal shockwave lithotripsy with PCNL for kidney stones of 1.5 centimeter to 2 centimeter in size and plus 250 Hounsfield to plus 1000 Hounsfield in depth. Urolithiasis is the third most common disease of urinary tract, exceeded only by UTIs and pathological conditions of the prostate. For moderate size kidney stone, currently we have both the options available, ESWL and PCNL, but ESWL is non-invasive, whereas the PCNL is an invasive procedure. So our aim is to find out the best procedure between the two for the renal stone size of 1.5 centimeter to 2 centimeter and Hounsfield unit of plus 250 Hounsfield to plus 1000 Hounsfield unit. The aim of this study was to compare the outcome of ESWL and PCNL for kidney stones of 1.5 centimeter to 2 centimeter in size and plus 250 Hounsfield unit to plus 1000 Hounsfield unit intensity.
The objectives were to assess the stone clearance, the complications, and to find out the advantages and disadvantages of one procedure over the other. The study was a hospital-based, prospective, non-randomized observational study, and it was conducted in our Department of Urology. Patients who give consent and between the age of 18 years to 60 years of both sexes and having the stone size between 1.5 centimeter to 2 centimeter with plus 250 Hounsfield unit to 1000 Hounsfield unit were included in our study. These were some of the exclusion criteria. The patient underwent standard PCNL procedure and standard ESWL procedure in our department. And the stone clearance was decided from the X-ray QV at 1 month of follow-up. And the X-ray QV was read by an uninformed radiologist or urologist, and the final result was noted. All patients were instructed to report any treatment-related complications, and it was treated appropriately and recorded. Ancillary procedures carried out if required, and patients were followed up for complications such as T-strata, infection, perineal hematoma, etc., and treated whenever required. A total of 150 patients were accrued in our study, and these patients were grouped in group 1 and group 2, where the group 1 underwent ESWL comprising 82 patients, and group 2 comprises 68 patients underwent PCNL. Both the groups, as far as the age and sex distribution is concerned, were comparable. The stone characteristics of both the groups were also comparable, but we can see that there multiple stones were treated by PCNL, and a slight difference we can see on the density of the stone also. It was a little bit higher for the PCNL group, but the data was comparable. This is the bar graph which shows the mean stone size difference in group 1 and group 2. And this bar graph depicts the location of stone in our study, the number of stones, whether it is single or multiple in different groups, and the Hounsfield unit in both groups. The mean number of ESWL sessions required for stone fragmentation or clearance was in between 2 to 3 sessions for ESWL. But PCNL, we were able to deal with all patients in a single setting only. And in mean shocks required to fragment or clear the stone were in the range of 3,000 shocks to 6,000 shocks. And we can see from this bar graph that the stone clearance was better for the PCNL group. And the ancillary procedure was more in the ESWL group for clearing up the stone. And the data, as far as complications are concerned, was also comparable, but we can see that there were few patients which have complications in ESWL group in comparison to the PCNL group. But surprisingly, to our notice, the Clevin-Dindo grade 3 complications were found to be more in the ESWL group in my study. The pie chart which represents the distribution of complications in group 1. Likewise, this is the pie graph which shows the distribution of complication in group 2. So our study found good stone-free rate for PCNL, and this finding is supported by most of the existing literature. As in most of the literature, severe complications were found in PCNL group. However, surprisingly in our study, we found more severe complications in ESWL group. And there were more single stones with less Hounsfield unit in group 1, but it was comparable to group 2, as these patients understood that they were very likely to achieve complete clearance with minimum number of ESWL sessions. And hence they opted for ESWL procedure. To conclude, PCNL has got better stone-free rate in this study group for kidney stones, with comparable complications and less requirement for ancillary procedures. And PCNL is a one-time procedure, whereas ESWL requires 2 to 3 sessions for this study group. And only disadvantage with PCNL is that it is inpatient treatment and it requires anesthesia, while PCNL is outpatient procedure and does not require anesthesia. It is the advantage of it. And these are some of my references. Thank you.
Questions are invited from the house.
Why do you limit the age group?
Sir, in older patient, in above 60 years, there is a chances of more complication in ESW and formation of perirenal hematoma. So we have limited our age up to 60.
Otherwise, question is how you distribute this group on a group 2?
So it was decided by the patient himself after explaining, and it was a shared decision making. Look, we have for moderate size stone, we have 2 procedures, ESW and PCNL. The ESW has sir. It was sir, it was a shared decision making. First, we informed him about all the procedures, and then he took, okay, I want to go for PCNL, and I want to go for ESW.
You said that this is one is OPG procedure. So actually, you get in the OPG.
Yes, sir. But it is OPD procedure. But the stone-free rate is less in ESWL, and it requires multiple sessions. All this is taken into consideration, patient chose accordingly.
And my last question is, what will be your advice on this procedure you will ask for?
Sir, for large stone, definitely I will suggest you to go for PCNL. And for small stone, my choice is ESW. But I have done my study in moderate size stone because there is a controversy, what to choose, what not.
Any more questions? Active participation is highly solicited. Any more questions? As a senior member in the profession.
Yes, sir.
Is it done routinely as an outpatient procedure?
Sir, ESWL. The ESWL we routinely do as an outpatient procedure in our department.
I heard it the other way. You told that PCNL is done as an outpatient procedure without anesthesia.
No, sir. PCNL
I heard it wrong.
No, sir. PCNL is inpatient treatment.
Okay. ESWL is outpatient.
Yes, sir. PCNL is that it is inpatient treatment and requirement.
Okay.
Sir, please give the mic to Sir then. Senior member in the profession. Sir, sitting in
the all the cases were radio opaque or not?
Sir, they were radio opaque, sir.
All the cases?
Yes, sir. Yes.
Okay.
Because
you said the follow-up is done by a DOB.
Yes, sir. X-ray.
I am asking
yes,
because uric acid is not visualized.
Yes.
That is
because they were moderate density range, sir, 250 hospital to 1000 hospital, so they were radio opaque, sir. We followed them with X-ray only.
Thank you.
I request Sir Kaku kindly to moderate the meeting.
Thank you, Dr. Anurag, for your nice presentation. I want to supplement on his answers. Actually, ESWL and PCNL are very different procedures. One is completely non-invasive, the other is invasive. So, we cannot randomize these patients. So we allow the patients to choose which procedure they have to undergo. And our common sense, everybody's common sense is that an invasive procedure is bound to have severe complications. An non-invasive procedure, people are not afraid. So we have taken up this study for this group of stone, 1.5 centimeter to 2 centimeter, with hardness of plus 250 Hounds per unit to 1000 Hounds per unit. It's where both the procedures can be done, but we allowed the patient to choose. And what we found was that even though PCNL is an invasive procedure, the complications of PCNL was comparable to non-invasive ESW. And surprisingly, as I said, the severe complications were in fact more in, though not statistically significant, more in ESW group. So what we are going to advise to our patient is that it is your choice whether you want to undergo PCNL by admission and under anesthesia, you can have a better chance of stone clearance. Whereas ESWL is a non-invasive, okay, outpatient, can come one day, then second session come after 1 or 2 weeks, the third session come after 1 or 2 weeks, but it's an outpatient, they can come, get treatment, go back. But the stone clearance is good, but not as good as PCNL. So it will be patient's choice. Thank you very much.
Thank you, sir. The last paper for today is from the Department of Medicine. Profile of COVID patients admitted at the Department of Medicine, RIMS in Pau, to be presented by Dr. L. Gayatri, Senior Resident, and moderated by Professor K.S.H. Virendra Singh.
Good afternoon, everyone. The topic of my presentation is Profile of COVID-19 Patients Admitted under Medicine Department, RIMS. A brief introduction. COVID-19 caused by the SARS coronavirus 2 has been one of the worst pandemic ever faced by the present generation. Originating in the Wuhan city of China, it has spread to almost all parts of the world, affecting 214 countries. The global tally stands at over 39 million cases and more than 1.1 million deaths. In this global race, India is at the second position with over 74 lakh cases and more than 1 lakh deaths. When India is in such a situation, how long could our state of Manipur escape? With the first case detected on 23rd March, Manipur now has over 14,000 cases and 109 deaths so far. The first COVID patient was admitted at RIMS on 31st March, and with the increasing number of COVID cases, the clinical scenario also keeps changing. Initially, we had only cases with travel history, and most of these patients were asymptomatic, and almost all of them recovered. This was the picture till the mid of July. However, towards the end of July, we started getting locally transmitted cases. And with the increasing number of locally transmitted cases, there has been increase in severity of the illness. Coming to the RIMS statistics, as on 15th October, 887 COVID patients were admitted, out of which 756 have recovered and 33 patients have died. Of these total patients admitted in RIMS, 630 patients were admitted under Department of Medicine, 109 patients were under chest department, and the rest of the patients in various other departments. Coming to our data analysis. We analyzed the data of those patients admitted under Department of Medicine from 31st March to 30th September 2020. Those patients who are still undergoing treatment as on 30th September were not included in the analysis as we were not sure about their outcome. And for some patients, some of the important parameters were missing, so those patients were also excluded from the analysis. And altogether, 413 patients were included. Our patients had a male preponderance, which comprises of 64.9% of the population. Age of the patients ranged from 13 to as old as 94 years. On dividing the patients according to age group, Majority of the patients belong to age less than 40 years, while only 49% of the patients were above 60 years of age. Altogether, 114 patients had pre-existing comorbid conditions, of which diabetes was the most common, followed closely by hypertension. Other comorbidities included malignancy, tuberculosis, liver disease, COPD, renal disease, and coronary artery disease. As many as 64.6% of the patients were asymptomatic, and the remaining patients, symptomatic patients, were further classified into mild, moderate, and severe based on ICMR guidelines. And we found that 6.5% of the patients had severe illness. Among the symptoms, fever was the most common, followed by sore throat, cough, and shortness of breath. Other less common symptoms were diarrhea, body ache, rhinorrhea, and anosmia. All the patients underwent routine blood investigations, chest X-ray, ECG, LDH, CRP, and D-dimer were done for some selected patients and other investigations whenever the need arises. Some of the important findings we got: 12 of our patients had leukocytosis, while 6 patients had leukopenia. And these patients had moderate to severe illness. 19 patients had high CRP, 68 patients had raised LDH, and 9 patients for whom D-dimer was sent were found to have higher levels, and all of these patients had severe illness. Raised liver enzymes were found in more than 50% of the patients, irrespective of clinical severity. And kidney function test was found to be deranged only in those cases of non-renal disease. The common findings in ECG were sinus tachycardia, pulmonary, T inversions, and right ventricular strain patterns. Now, coming to the most important investigation in COVID in our institute, chest X-ray. 91% of the patients had normal chest X-ray, while the remaining of the patients who had abnormal chest X-ray findings, they had a variety of findings. The most frequent being multifocal lower lobe predominant consolidation, followed by multifocal bilateral consolidation. Other patterns include reverse battering, peribronchial consolidations, ball pattern, and diffuse lung involvement. Some examples of the X-rays: this X-ray showing a round pneumonia, bilateral diffuse lung involvement, again bilateral diffuse lung involvement with more severe involvement of the right side, again bilateral multifocal consolidations, this rounded consolidations, reverse battering pattern, bilateral lower lobe predominant consolidation, again bilateral lower lobe predominant consolidation, peribronchial consolidations, another example of rounded pneumonia. Coming to the oxygen requirement. As many as 88.9% of the patients did not require oxygen support. However, the remaining who required oxygen support, 29 of the patients were able to maintain saturation with face mask, 6 of the patients were on non-rebreathing mask, 9 patients were on non-invasive ventilation, and only 2 patients were intubated. The mean duration of positivity range was 12 plus minus 5 days. That is the number of days between the first positive result and subsequent first negative result. However, as the clinical severity increases, a negative result does not always mean clinical recovery. And in our study, we found 12 patients for whom clinical recovery was delayed, ranging from 4 days to as long as 28 days post-negativity. Out of the 413 patients, 399 recovered and were discharged, and 14 patients died. Of the 14 patients who died, 7 were males, 7 females, 11 were in the age group of about 60 years. 4 patients had diabetes, 2 each had hypertension, malignancy, and liver disease. Another 2 had CKD with hypertension with type 2 diabetes, and 2 patients were without comorbidities. When we further studied the percentage of the occurrence of death in each category, 22.4% death occurred in the age group of about 60 years, and it was the occurrence of death was more among the females, and among the comorbidities. So the number was higher among diabetics. The percentage was much higher among those with malignancy, liver disease, and renal disease. To conclude with, I would like to say that as the number of COVID cases increase rapidly in number as well as in severity, our healthcare facilities will soon get exhausted. And here comes the importance of segregating those with higher risk of mortality. From our analysis, we found that old age, diabetes, hypertension, malignancy, liver, and kidney diseases are associated with increased risk of severe illness and death. And also, I would like to emphasize on the role of basic investigations. Chest X-ray being the most important, as it is inexpensive, easily available, convenient, and very much reliable. Another is the total leukocyte count, LDH and CRP, important prognostic markers, and D-dimer is very important, though it is not available in our institute, and hopefully it will become freely available very soon. Thank you.
Wonderful presentation, Dr. Director. How frequently should the D-dimer test be done?
For our patients, initially we didn't do for any of the patients and it was not available inside. But as the clinical severity increased and D-dimer is very important to guide our treatment strategy, we started sending for some of the severe cases, and it is sent outside, so it's quite difficult for us to send. So we sent at baseline and decide the treatment, and sometimes when patients are more severe, we try to send, actually it should be sent very frequently to know the improvement, but we are able to send mostly once and after 5-6 days.
Questions are invited from the house.
Right, 2 cases were intubated.
Yes, sir.
How about the
Dropping saturation and requirement of very high FiO2 or NIV, sir.
What happened to them?
So honestly speaking, since we were not inside the COVID ward, we don't have the detailed idea.
Why I say that once intubated, the prognosis is very, very poor, very unlikely to come back. Management by NIV and those things are quite commendable. That's what I.
So those 2 cases were actually intubated, and soon after intubation they expired.
That's why I wanted to know. And the investigation profile, what I saw was that you were all depending on the chest X-ray. Did you require in time use a high resolution CT test?
So it was not at all possible. COVID patients could not be taken inside the CT room.
So we don't indulge in the.
No, not at all, sir. It would be very good if they give another CT machine for the COVID patients, but as of now, we don't have the facility. Even the D-dimer is not available inside.
Very excellent presentation by Dr. Gayatri. I have many queries. With the permission of the chairperson of the Medical Society and the Medical Secretary, may be allowed to ask a few questions. First question is there any method of triage of the COVID patients? Like, are there any criteria according to which you can classify which patients will go into that have a very bad prognosis, they are likely to die, and which patients are likely to recover? That's my first question. Second question is, suppose a patient, old patient around more than 70 years, having comorbidities, he tests negative after 10 days of the first positive result. Is it safe for such a patient to be discharged home? And if so, if he stays with another patient, another family member who is asymptomatic COVID positive, what are the chances that he might contract COVID?
Thank you, sir. Regarding the first question, the aim of our presentation was to highlight the importance of triage, because as of now, such a system is not very much into action. Though we do among ourselves clinically, we decide our patients which will require more invasive investigation and which are less likely to progress into severe illness. We do it ourselves, but not at the institution level. So there lies the importance. And those comorbidities which I have highlighted as being the risk factors, and also the importance of those basic investigations, not going to very high investigations, but those basic investigations. If we do at baseline, and if we do at regular interval, we will know that such patients will not progress into severe, with very less chance of progressing into severity, and those who are more likely to progress into severe illness and subsequently death. And as for the second question, even if all patients with comorbidities, yes, they are at very high chance of severity, but COVID is something which all of us, honestly speaking, we do not know much about this disease. And sometimes miraculously, that 94, I have in my presentation, I mentioned that the oldest age was 94 years and another was 92 years with type 2 diabetes. Both of them improved. Both of them improved and were discharged. And one of them didn't even require oxygen support. So we do not know, maybe because the viral load was less, or he was exposed to a lower, less virulent strain of the virus, or the number of virus infecting in his body was less, or there may be some genetic predisposition on it. And another important thing is that during our data collection, we did not know these things, so we did not collect in detail, but medication history is also very important. For example, diabetic and hypertensive, those who were taking AC inhibitors and diabetes and hypertensive, they are more likely to get infected and also to progress into severe illness. So such history were not taken. So these may be the deciding factors also. Thank you.
Very nicely answered. What about the point regarding his discharge after 10 days, after testing negative for 10 days?
As we all are not sure about the persistence of antibodies and we do not test antibodies, we are not sure about it, but certain studies claim that after 12 days of infection, patient becomes non-infectious to others. So if the asymptomatic patient is saying that the old man has crossed 12 days, then he is at least to some extent he is safe from further infection. And we hope that the antibody will at least persist for some days after recovery.
Okay, Dr. Anuruddh, yeah, please.
Suppose the patient is symptomatic, without respiratory symptoms. So whether it will benefit us to know the de-diagnosed status and start low molecular weight prevalence to prevent the symptomatic to prevent the symptoms of respiratory.
You mean patient? Do you mean that patient has shortness of breath but saturation is normal?
But these symptomatic.
Symptomatic in one sense. Okay.
So whether it will help us to get and de-diagnose and to start providing low molecular weight prevalence to prevent the respiratory symptoms.
Since the patient, okay, you mean the patient doesn't have respiratory symptoms but other symptoms. We do not treat only based on the dimer. Other investigations will also be sent based on the X-ray, day-to-day saturation, day-to-day progress of the symptoms, whether there is any drop in the saturation in between, whether there are any fever, and if the stress X-ray is completely normal, we may withhold. As for now, we are following ICMR guideline and some AIMS protocol. So in that guideline, what they say is that for mild cases, we do not require this low molecular weight heparin prophylaxis. And in that categorization, the main emphasis is given on saturation. If X-ray findings are there and if saturation drop is there in between, we will surely start, but we do not treat only based on the dimer.
I think there are no more questions. May I request Virendra?
Hello, Dr. Mansubi. Hello. There is a question from Ravin Rai that how many COVID patients with comorbid conditions, severe comorbid conditions, have recovered at Dreams Hospital?
I think it was already mentioned in the study, but still, Dr. Gayatri.
There were, as of 30th September, that is our study period, there were 114 patients with comorbidities, out of which 12 have died. So 102 patients with comorbidities have recovered till 30th September.
So this was the question from Rabin Rai. I think you have answered it. Thank you very much.
So are there any more online questions regarding other subjects? We will take the online questions after this moderation.
Very good afternoon to all respected members, Rajan and esteemed members of the society and all the attendees. At the very outset, I'd like to congratulate and thank Dr. Mansubi and our team
for this innovative way of conducting hostile way of medical study of this session. For the presenter, I actually bought the research that I did for her extent presentation also. It was very nice because it was the first analysis of COVID patients admitted under the Department of Medicine. Other comments are also there, but medicine is the maximum number. So we have got 630 patients out of the 887. So all this we have analyzed the data of 413 patients. Due to the time constraint, we have taken out some slides, but we are through more than 6 months of COVID pandemic now, and in the first half of the period, mostly the patients we have returnees from outside. They were younger in age group, and they were asymptomatic or mildly symptomatic, and they didn't have comorbidities, except a few patients with comorbidities who took treatment from, say, Mumbai and Delhi or Sultan or Guwahati, and they returned in a different case. But most of them, they recovered, and they constituted about 65% of the whole population of COVID patients in our hospital. On the contrary, in the second half of this period, means in the last two plus months, we have seen that the patients are coming from the Syrian population, indicating that they got infection from the community itself. The community transmission is there. They are not returnees. They are older in age, and they have got many comorbidities, not only one, but maybe 2 or 3 like that. And they are symptomatic, moderate to severe, or some are very critical, and they consider about 35% of the population. This may be because of the sales policy of admission in RIMS, because in other community COVID care centers are there, so small diseases are there, so only severely affected or moderately symptomatic patients are admitted in our hospital. So of these common comorbidities we have come across was diabetes is very common. Diabetes, hypertension, tuberculosis, kidney failure, CKD, liver diseases because of alcohol or some other causes, tuberculosis, COPD. These are common comorbidities we have come across. And they were admitted usually in COVID ward, during COVID ward, previously known as A, now is not C. Previously COVID ward A was having 42 beds. Now we are having 74 beds because we increased. And we have got 17 beds available for ICU. And here in the COVID ward, if they have got certain symptoms, for example, they deteriorate. If we classify them as moderate to severe according to the SpO2, it means partial symptom. Soreness of breath, okay, mild. But if it's increasing soreness of breath, if the respiratory rate is more than 24, moderate. More than 30, very severe. SpO2 less than 90 to 94% by simple pulse oximeter is moderate. If it is below 90, then severe. So depending on the symptom and the SpO2 and the respiratory rate, we price them as moderate and severe. Moderate to severe, of course, they are indication for admission in the ICU. In the ICU, of course, the first thing is oxygenation. Oxygen is given, oxygen, and only 2 patients they were intubated. Others were okay with the high flow oxygen and or NIV, non-invasive ventilation, or non-breathing chest mask, and also they could be managed in the ICU. And the indication for other treatment, of course, treatment is mentioned by the guide is we are following the treatment protocol developed by treatment core committee of RIMS. This is a modification of ICMR guideline and AIMS guideline. In AIMS guideline, initially we had broken. So since it was found that it was not very effective, so we took it out. So we replaced with some other way. And ECMO is not available in our setting, or for example, CPT means convalescent plasma therapy is not available in our setting. So these are not followed, but others are almost same. So these are the indications for this one. So here, if they deteriorate in condition, for example, hypoxia is still persisting, And then if the laboratory parameter, for example, rising CRP, LDH, these two are available in our hospital. LDH and CRP is available in our hospital, but D-dimer is available in private hospital. Two hospitals are available. So in some cases, we have seen D-dimer. So these CRP, LDH, and CRP, D-dimer, and X-ray. X-ray is very common because we have got X-ray machines, dedicated X-ray machines in the COVID ward and the ICU. So we can take help of them. So if the findings are there, these are indications for steroid low molecular heparin. So an indication for low molecular heparin for doctor's question is because of these findings. Because moderate to severe one, and if you think that this is because of pulmonary microvascular thrombosis. So in that case, is the indication for low molecular. Simple symptomatic fever, myalgia, headache. Even if they are high febrile, if they don't fall into moderate to severe, we don't have to give. So steroid and this one low molecular we give in the moderate to severe one indications are there, and. Some of the patients, those were two individual patients, they could not be shared, of course. But some patients, they recover. Mostly, they recover in the period of 12.5 days. But some patients, they became negative. But they could not be sent away because of the persistent hypoxia. So they have to be shifted to the general ICU. And even in the ICU also, after some time after observation, they have to be shifted and being further observed in the ward. So such cases we had about 3% of the all cases. Some of the total cases, 3% of the cases they require prolonged hospitalization, even if they became COVID negative. And of these. Third question was there, and there was triage is depending on their symptoms. As I have mentioned, symptoms of increasing dyspnea and respiratory rate increasing, and they complain to us, okay, I'm having so much of this, and then we do the SPO2 is falling. Then of course this indication for the triage, or in the case we shift them from the COVID ward A or C to B. B is the ICU. So this is triage. And then regarding the discharge, after 10 days, protocol is there, ICU protocol is there after 10 days from symptom onset or 3 days beyond a febrile period, and then they can be discharged. But for us, just modification means, better modification means, we test them. If they tested negative, then of course we discharge them and ask them to stay for another 14 days at home, this quarantine, because some of them may develop antibody, some may not develop antibody. Those who develop antibody, we cannot say. Those who develop antibody, even if they stay with a positive person, they won't get infected. But some people may not develop antibody. So for just to avoid that reinfection, though reinfection is very, very rare. So as a SOP of the government and ICMR, so they should be quarantined, home quarantine for another good period here. And for D-dimer, D-dimer, I've already answered, I think. And our X-ray, CT scan. CT scan, we want to do CT scan because CT scan is a very good parameter, findings are good parameter of severity of and treatment strategy for this one. But we cannot do CT scan because we have a single CT scan, and if it's exposed, then everything will be difficult for us to manage non-COVID patients. So in next few months or maybe the next plan, maybe they might have some CT scan, dedicated CT scan for that patient. But right now we don't have that one. But we are managing with X-ray, which is as good as CT scan. Though not very good, of course, but it's quite good for us, I think. And the take-home message is that for all of us, for all the doctors, for our colleagues, we want to impress again that for our family members, our parents, our relatives, and our patients, those who are having comorbidity, especially diabetes, hypertension, they should have a very strict control of their disease, because tight control of diabetes is must. Otherwise, the prognosis is worse for them. Those who are having comorbidity, the mortality is more as compared to the non-mortality. For example, in 14 cases, only 2 cases they didn't have any comorbidity. So they develop very severe disease because of the extensive microvascular thrombosis in the lung. So lung damage was there, and remaining one is 20%. They expire because of the comorbidities. So and then one more thing is that those who are negative still cannot be sent away because of hypoxia. If we ask them to stay for longer period, they recover. For example, we've seen in a few cases, they recover, they tested negative, but they couldn't be sent home, but they stay and continue with oxygen, and slowly the lesion heal. So I think time heals their lungs also. This is a good message. And please take care of yourself and everybody. And at the end, I would like to thank our respected medical officer who supplied some of the data to us for our analysis. Thank you very much.
Thank you, sir. Very nice presentation and very nice innovation and very relevant. Executive members of the Medical Society, can you come to a conclusion regarding the test paper? I request our respected chairperson kindly to announce the name of the test paper.
Hi, hello everyone. I think you must be waiting for this for a long time. The best paper for today's scientific session goes to Dr. Laurembam Gayatri, Senior Resident Medicine Department. Thank you. Dr. Gayatri, your prize, we have not arranged it because we were in a very hastily mood. That is why we could not arrange your prize. So we will send you your prize surely. Thank you.
We will deliver a beautiful gift for your department. COVID-free. Now let us start with the distribution of the certificates of the speakers. May I request Rajan kindly to do the honor of giving the certificate to Dr. P.G. Sarungan, PG from the Department of Orthopedics. Sorry, Nathan. Sorry, I'm participating over there.
Yes, I would like to share with all of you this particular society. When I joined RAMS in 1984, it was functioning in our next to director's room where we were living. And from such a long period without any interruption, and this is going on. It's a wonderful venue, and for any to develop or scientific study, we require this type of publication and the same publish or perish. If you don't publish, you will perish. Understand? And nowadays, you are very lucky. Nowadays, we used to present with the overhead projector, transparency, and so on. Today, with your finger in the night also, you can make your slides, result. Those days, if there is no sunshine, your this one will be dry up. Because and once it gets stuck in your projector, then it's now we are very lucky, and our institute today, is a landmark in the history of the medical society, going to webinar, really goes to your team by Professor Kakro, and so we are very good student of mine, and very happy, only for us so anyway, please keep up, and this is something, we have to get the town of this world institute, Residential Medical Sciences. When I joined, the name was RMC, then NERMC, then RIMS, so on. So how it is scaling higher and higher heights. So once again, I thoroughly enjoyed. Actually, some of you, I don't know, me know or not, I'm a retail, but not tired. I repeat, I'm retail, but not tired. And this is the point that in the Department of University, I'm working as a contract basis. So I thought today, the first day, I go and there as a chairman, very dynamic, full of knowledge. So thank you very much for allowing me, giving me the opportunity to hand over this certificate. Thank you.
Thank you, sir. Thank you, sir. Next, may I call upon our respected chairperson, Sir Raku, kindly to give the certificate to Dr. Janet Moran.
Thank you very much for coming, sir.
Next, thank you, sir. Next, may I call upon the head of Department of Medicine, Sir Dhanraj, kindly to give away the certificate to Joshila Devi, Dr. Joshila. I would like to now call on Sanjay Chandra of PMR kindly to give the certificate to Dr. Shamin. May I now call upon Madam Gayatri kindly to give the certificate to Dr. Anurod. Today we are so thrilled with the active participation from all the members here. So lastly, may I call upon Sir Virendra and Sir Devin, if you don't mind, kindly to give the certificate to, there's only one participant left, Dr. L. Gayatri.
Dr. Gayatri is supposed to get two. So we have only one. That's why we're calling two. We have more.
This is the certificate for the best paper. Thank you. Please, we have arranged some refreshments outside. This refreshment can be taken home. Eating together is not safe, so you can take it home.
can remove that.